Hello, and thank you for joining the Pituitary Network Association's webinar program, which is brought to you through the support of our sponsors and our expert contributors. The PNA is dedicated to educating people with pituitary disorders, their families, and their healthcare providers. The PNA is a nonprofit organization that relies on the support from our members and donors. During the webinar, please feel free to type in your questions at any time. Please note that all questions will be saved until the end of the webinar. We have allotted time to answer as many questions as possible. Today's webinar being presented is Surgical Management of Functional Pituitary Tumors. Please hold as we will have a brief delay while we change presenters.
Okay, hey there everybody, thanks for having me here. So today I'll be talking about the role of neurosurgery, especially for functional pituitary tumors. Let's see if I can minimize this so you can see my screen here. Just let me know if it goes mute or you can't see my screen. But my name is Dr. Chaichana. I'm a professor of neurosurgery at Mayo Clinic in Jacksonville, Florida. I'm also the director of pituitary and skull-base surgery here at Florida. And so the overview is that I'm going to be talking about the epidemiology of pituitary tumors, more specifically the epidemiology of functional pituitary tumors and what functional pituitary tumors are, endocrine and imaging workup for functional pituitary tumors, surgical considerations and management for these functional pituitary tumors, postoperative care, case examples, and then conclusions. In the case examples, I'll show you some operative videos. So if those are too grotesque or please turn away for a little bit while I show those videos. I find that these videos are very helpful for physicians and patients to see what the pituitary surgery entails. So for pituitary tumors in general, they arise from the anterior pituitary gland. The pituitary gland actually has two components. It has a front part and a back part, also called the anterior and the posterior part. Pituitary tumors arise from the front part of the anterior pituitary. The anterior pituitary is the part of the pituitary that produces hormones. So this can produce tumors that produce hormones and tumors that don't produce hormones. Pituitary tumors are the second most common benign intracranial tumor after meningiomas. They account for approximately 16% of all intracranial tumors. The prevalence of it varies depending on the imaging availability in the country that was studied, but varies from 1 to 865 to 1 to 2,688 adults, which is around 1 to 1,000 adults. So 0.1% of the population has a pituitary lesion. Most of the pituitary tumors are considered non-functional, which are non-hormonal tumors, which I'll talk about a little bit later. This varies from 15 to 54%, but most studies show that this is more common than the functional pituitary tumors. The majority of these pituitary tumors are considered macroadenomas. It's based on the largest size diameter of the tumor. If the largest size diameter of the tumor is greater than 10 millimeters, it's considered a macroadenoma. Things below 10 millimeters are considered microadenoma. Giant pituitary tumors are usually considered greater than 40 millimeters or 4 centimeters. So non-functional tumors, like I mentioned before, are tumors that don't produce clinical symptoms based on hormones. So these are cells types that are considered null cell, or tumors that do have hormonal staining that stain for lactotropes, which is prolactin, somatotropes, which stain for growth hormone, thyrotropes, which stain for thyroid stimulating hormones, corticotrope, which stimulates for cortisol producing hormones, and gonadotropes, which stimulate for things like FSH and LH, which are different hormones, but they don't create clinical symptoms related to their functional status. These are considered non-functional tumors, and this is the majority of the pituitary tumors. Less common are the functional tumors. These are the tumors that produce hormones that cause clinical symptoms. So the lactotropes are a group of functional pituitary tumors that produce prolactin, and I'll talk about those symptoms later. The group of functional tumors called somatotropes release growth hormone, which cause clinical symptoms of acromegaly. Corticotropes, which release ACTH, which is a hormone that causes increased steroid production in the body that causes a clinical syndrome called Cushing's disease. And then thyrotropes, which release thyroid stimulating hormones, which causes another type of functional tumor. So these are the two major categories of pituitary tumors. There's the non-functional and the functional tumors. The non-functional tumors are more common than the functional tumors, but the functional tumors are more specific relating to surgery. So the most common type of functional pituitary tumor is a prolactinoma. These are the tumors that release prolactin. They're also called lactotropes. They can comprise 66% of functional tumors. They're more common in females than men by 10 to 1. In females, microadenomas, which are tumors less than 10 millimeters or less than 1 centimeter, are more common in females, while the larger tumors are more common in males. Some of these tumors, though, can be very large. Up to 5% of them are giant, which is considered greater than 40 millimeters or 4 centimeters in diameter. The second most common type of functional pituitary tumors are acromegalics or acromegaly producing tumors or growth hormone producing tumors. These are the tumors that release growth hormone that cause the clinical symptoms of acromegaly. They account for 9 to 13% of pituitary tumors. They're equal in presentation between females and males, 1 to 1. The majority of these are macroadenomas, consisting of approximately 73%. These are commonly diagnosed in the 50s. Cushing's disease is the next most common. They're quite rare. They account for 4 to 6% of pituitary tumors. They're more common in females than males by 3 to 1. 33% of these are large and 12% are undetectable. What that means is on imaging we can't find them, but the patients have hormonal status that's consistent with Cushing's disease. The least common, which are very rare, in fact I've never seen one, is a thyroid stimulating hormone. It accounts for 0.5 to 3% of pituitary tumors. They're equal in distribution between females and males, and the majority of these are large. So for this presentation, I'll be mainly focusing on the 3 most common type of functional pituitary tumors, which are the prolactinomas, the growth hormone producing tumors or the acromegalics, and the cortisol producing tumors or the Cushing's disease. So in terms of prolactinomas, once again, they're the most common type of functional pituitary tumor. They comprise 66% of functional tumors. They're more common in females than males. In females, they're more commonly smaller tumors, less than 10 millimeters, while in males, they're commonly larger than 10 millimeters. And some of these tumors can be quite large, up to 5% are giant. The genetics related to this are typically not hereditary. They're caused by a mutation in the pituitary transforming gene, as well as the fibroblast growth factor 4 gene. They're typically sporadic or non-inherited, but they can occur in some hereditary types called a multi-endocrine neoplasia or MEN type 1 syndrome. The symptoms that they typically cause are regional mass effect or regional pressure on the surrounding structures. They can cause pressure on the optic apparatus. So here's a prolactin tumor that you can see here. The optic apparatus is up here and you can see it's elevated. When that happens, you can have visual field loss. Cavernous sinus are the blood vessels to the side. Those can cause cranial neuropathies such as double vision or eyelid opening problems. And it can also compress the normal pituitary gland. In this case, the pituitary gland is smashed down to the bottom, and that can cause pituitary dysfunction and sometimes pituitary bleeding, leading to pituitary apoplexy and complete pituitary dysfunction. Sometimes they can be increasingly large and comprise and block off the ventricular system, which are these fluid-filled systems here, causing hydrocephalus. They can also cause symptoms related to their hypersecretion. So increased prolactin production in the body can wreak havoc. In men, it can cause decreased libido and impotence. In women, it can cause menstrual irregularities, infertility, and galactorrhea. Galactorrhea is an expression of milk from the breast, even when the patient is not lactating or not breastfeeding. Sorry. It can also cause effects in children, including puberty delay, growth arrest, or primary amenorrhea, where they don't develop their normal menstrual cycles. The second most common type of functional pituitary tumor are acromegalics, which is due to a release of growth hormones. They account for 9 to 13% of pituitary tumors. They have an equal distribution between females and males. 73% of these tumors are large or macroadenomas. That means they're greater than 10 millimeters in diameter. They're commonly diagnosed in patients in their 50s. The genetics are that they're not commonly hereditary, but they can also occur in different types of syndromes, including multiple endocrine neoplasia type 1 and type 4, as well as others. The symptoms similar to pituitary tumors and as well as non-functional tumors, they can cause regional mass effect on the optic apparatus, causing visual field problems, cavernous sinus causing cranial neuropathies, which include double vision, cranial nerves, which are within the cranial cavernous sinus, as well as pituitary gland dysfunction, leading to pituitary apoplexy. The common symptoms for someone with an acromegalic, they kind of look like this picture. What happens is the growth hormone causes dysmorphic features of the patient. It causes prognathism. What that means is it increases their jaw, where they have a very prominent jaw, prominent chin. It can also cause a malocclusion of the jaw because the jaw grows so large, and as well as teeth spacing. It can also cause frontal protuberance, where the forehead becomes more prominent. It can also cause what's called acral overgrowth, where the hands and the feet become bigger. Some patients that I've seen have had 2 ring sizes or even 2 to 3 feet sizes, shoe size increase over time. It can also cause arthritis or joint pain because of the bone growth, and as well as soft tissue swelling, where they have increased soft tissue around their joints, including their shoulders, their elbows, their fingers, and their knees. And sometimes patients have undergone several hip replacements, knee replacements because of this before it's diagnosed. And in children, if it occurs early and causes giganticism, Andre the Giant was a wrestler who had this giganticism, and even some NBA players have symptoms related to this. The next most common functional pituitary tumor, the least common that we typically see, is Cushing's disease. They account for 4 to 6% of the pituitary tumors. It's more common in females than male by 3 to 1. 33% are macroadenomas, which means the majority are microadenomas or less than 10 millimeters in diameter. In fact, 12% are undetectable, which means we can't detect them on imaging because they're so small. They're mostly diagnosed in patients between the ages of 20 and 30. And the unfortunate issue is that it takes several years for the diagnosis because they go through patients typically undergo several tests looking for something else before a Cushing's disease diagnosis is obtained. They're typically sporadic or not hereditary, but they can occur in a variety of mutations, including the somatic activating gene, APC gene, and in multiple endocrine neoplasia type 1. Similar to the other tumors, when they become large, they can cause regional mass effect on the optic apparatus, cavernous sinus, and cranial nerves, as well as the pituitary gland. Related to their hypersecretion, which causes the Cushing disease syndrome, is a picture here. So some of the symptoms related to that, because the cortisol is a steroid production that's usually done when in a flight or fight response. What that means is when you're stressed, your cortisol level typically goes up. But for a patient with Cushing's, that stress hormone is constantly released. This can cause havoc to the body, causing diabetes, obesity, high blood pressure, high cholesterol, osteoporosis or thinning of the bone, as well as psychiatric issues, including depression. Some of the common features that you can see in this picture here is that the patients have thinning of their hair and even hair loss. They develop acne on their face, even though they are not prepubescent or going through puberty. They have central adiposity, which means they increase their abdominal weight or abdominal weight gain while their muscles thin in their arms and their legs. They also have an enlarged dorsal cervical fat pad, also called a buffalo hump, which is this increased fat pad in the back here. They also have abdominal stria, which are stretch marks along the abdomen and chest area because of the growth of the skin, because of the increased weight gain in that area. And the skin changes where you see easy bleeding, easy bruising, and thinness of the skin. It can also cause amenorrhea or lack of period in women, as well as decreased libido in men. So how we work these up, so I'm a neurosurgeon, so I rely on my endocrine team for this. We have a very good endocrine team that specializes in pituitary workup. And so this is typically done by the endocrinologist from the endocrine side, and then we get imaging to confirm the presence of the tumor. So typically when a prolactinoma or prolactin-producing pituitary tumor is suspected, this starts with the serum prolactin level that's typically elevated. Typically, depending on the age, the range of the prolactin is typically 15 to 45. Anything that's greater than that is concerning for a prolactinoma. Typically, it's in the hundreds to even thousands. So when you have an increased prolactin level, what we have to make sure first is it's not due to other causes. Things that can elevate the prolactin outside of a pituitary tumor include pregnancy, medication side effects, especially antidepressants. If you have low thyroid, it can cause an elevation in the prolactin level, or other causes of mass effect on the pituitary stalk. So the pituitary stalk is the structure that connects the pituitary gland to the brain. When the pituitary stalk has pressure on it, it causes the pituitary gland to release prolactin, even though the tumor itself is not producing prolactin. Things like cysts, meningiomas, or other pituitary tumor or other tumors can cause pressure on the pituitary stalk, elevating the prolactin level. That's not due to a prolactin-producing pituitary tumor. You also have to rule out something called macroprolactinemia, which is an aberrant laboratory finding that shows an elevated prolactin, even though it's not true. It's just an aberrant laboratory testing issue. And so when the prolactin level is elevated, you want to do a repeat measurement that you can see here in this diagram to confirm the elevation of prolactin, as well as ruling out the secondary causes, which I mentioned before, which are thyroid hormone, low thyroid, medication side effects, pregnancy, etc., as well as macroprolactinemia, which is done by checking a macroprolactin level. You also want to do a dilutional test to confirm the actual value of the prolactin. Sometimes the prolactin level will show elevated, but it's actually more elevated than that because of what's called a hook effect. Basically, the test is overwhelmed by the level of prolactin that it shows an aberrant level that's actually really higher, so you need to do dilutional tests to confirm the actual prolactin levels. So once you have an elevated prolactin level, rule out the other causes, rule out macroprolactinemia, do a second test just to confirm the elevation of prolactin. Once you have the elevation of prolactin, typically leads to an MRI imaging of the pituitary gland to look for a pituitary tumor. If you see a large pituitary tumor greater than 10 millimeters, it goes into this category and you start treatment. And we'll talk about the treatment later, but it's typically medical. If it's less than 10 millimeters or normal pituitary gland, you determine if the patient is asymptomatic or symptomatic from the prolactin. Remember, in men, it can cause decreased libido or impotence. In women, it can cause infertility, galactorrhea, which is lactation from the breast, even though they're not breastfeeding. And then you follow up the prolactin value, or you do treatment if they're symptomatic. You also want to do a visual field testing if the tumor compresses on the visual apparatus to make sure that the patient does not have a visual field problem from the pituitary tumor. An important note is that some pituitary tumors also release growth hormone, so it's important that you undergo growth hormone testing as well. For acromegaly or growth hormone producing, the workup is similar. So if you suspect acromegaly or elevated growth hormone levels, you get a serum growth hormone level as well as an insulin-like growth factor level. The growth hormone level is not very reliable because it's cyclical. What that means is during different times of the day and as well as different times during the menstrual cycle, the levels can go up or down, can be normal or slightly abnormal. The more important thing is what's called an insulin-like growth factor. So when the pituitary gland releases growth hormone or growth hormone releasing hormone, it causes growth hormone to go up. The growth hormone activates in the liver, causing or other organs, including muscle, causing a release of insulin-like growth factor level, so that's more stable to evaluate if a patient has acromegaly or elevated growth hormones to check the IGF-1 levels. You also want to do an oral glucose tolerance test where the patient gets glucose and you want to evaluate if the growth hormone is suppressed. If it's not suppressed, it's most likely consistent with acromegaly. Similar to pituitary tumors that release prolactin, some of these tumors that release growth hormone can also release prolactin. 25% of the patients with acromegaly have a tumor that also releases prolactin, so it's important that you also undergo prolactin level testing. So when you suspect acromegaly, you want to check the IGF-1 level as well as the growth hormone, but the IGF-1 level is the one that we more focus on. You also want to confirm acromegaly with an oral glucose tolerance test if the IGF-1 levels are elevated. To confirm the presence of acromegaly as well as the growth hormone levels. Once you do that, you undergo imaging to look for a pituitary tumor, and similar to other tumors, if it's pressing on the optic chiasm or the optic apparatus, you want to undergo visual field testing. With acromegaly, similar to Cushing's, it can cause havoc on the systemic system. So some of the things that can be related to acromegaly are diabetes, high blood pressure, and cardiovascular disease, as well as sleep apnea. So you want the patient to undergo testing for these as well. And so that's the workup for acromegaly, similar to prolactin. And the last is Cushing's disease. This is a little bit more complicated because oftentimes patients with Cushing's disease can have Cushing or steroid production from other parts of the body outside of the brain, in which case it's called Cushing syndrome rather than Cushing's disease. So when you suspect Cushing's disease, you want to rule out what's called exogenous steroid administration. So if the patient is getting steroids for their asthma or for some other reason, this can cause Cushing's-like disease, but it's not Cushing's disease. It's caused by exogenous or outside steroid administration. Typically, you want 2 positive tests. So you undergo a 24-hour urine cortisol where the patient collects their urine for 24 hours and you evaluate the cortisol level. You can do a late-night salivary cortisol, which you check their cortisol levels within their saliva overnight because this level should be the lowest. Or you do a dexamethasone suppression test, which is either 1 milligram for an overnight test or a 48-hour test, which is 2 milligrams for a suppression test. If you have 2 of those 3 findings or ambiguous findings, you can also undergo other tests, including a midnight serum cortisol level in the blood, as well as a dexamethasone cortisol releasing hormone suppression test. You can also do ACTH levels to confirm the presence of a pituitary cause. Like I mentioned previous, other parts of the body can also release steroids, including the adrenal glands. So it's important to distinguish Cushing's disease from the pituitary gland versus outside, and the ACTH levels will show that. An elevated ACTH level confirms a pituitary cause as opposed to an adrenal cause. Once you suspect and confirm Cushing's disease, then you undergo imaging. Typically, this is an MRI pituitary with and without contrast. Typically, we do dynamic imaging for lower tumors or smaller tumors. What dynamic imaging means is that once a contrast is administered, the radiologist will take pictures of your pituitary gland or take pictures of the patient's pituitary gland at frequent intervals to see if a tumor is highlighted. So what happens typically is the pituitary tumor does not administer or uptake the contrast as readily as the pituitary gland, so it appears as a dark area on the scans, but this can occur later, and over time, the pituitary tumor will take up the contrast. So this is a way to detect very small lesions. If it's ambiguous still, if there's a pituitary lesion, the patient can undergo what's called an IPSS testing. That's an inferior petrosal sinus sampling test. An inferior petrosal sinus sampling test is typically done by neurointerventional radiology, where they go and access the groin. They access the femoral artery through the groin, and they obtain different levels of cortisol production from both sides of the pituitary gland after administering hormones to see if there's a laterality or a central base for the Cushing's disease. So what it allows us to do if we can't see a tumor on the MRI scan is to evaluate if the pituitary is the source and if there's a site for the lesion, since we can't see it on imaging on an MRI scan. There's also other types of imaging called a CIS sequence that looks at higher resolution of the pituitary to see if there's evidence of a pituitary tumor. For larger tumors, we undergo visual field testing to make sure that the patient doesn't have a visual field deficit or peripheral field deficit. And if there's a non-central or non-pituitary source, the patient should undergo a CT of the abdomen and pelvis with contrast to evaluate for another source of steroids, which could be the adrenal glands or the lung in cases of lung cancer. So for surgery, for prolactinomas, like I mentioned previously, prolactinomas typically we treat with medical therapy in most circumstances. The reason why is that these tumors typically respond very well to dopamine agonists. Dopamine is a drug that is produced in your body, but you can also administer it that decreases the production of prolactin by the pituitary tumor, sometimes even resolving the tumor. So when you suspect a prolactinoma and you confirm it with laboratory as well as imaging testing, the patient can be administered dopamine agonists, which include bromocriptine and cabergoline. These cause remission rates in patients with prolactinomas from 15 to 80% after withdrawal. The patients that have the best responses to these medications are those that undergo 24-month duration of treatment, those patients that achieve normal prolactin levels with administration, those patients with greater than 50% reduction in tumor volume, and those that require low dopamine maintenance doses. The side effects of administering these medications is that it causes pituitary apoplexy. What that means is pituitary hemorrhaging, which lead to pituitary dysfunction, which is very rare, but it can happen. For large tumors, it can cause CSF leaks or cerebrospinal fluid leaks. Cerebrospinal fluid is the fluid that bathes your brain and spinal cord, and when the pituitary tumor is large and it melts away with the bromocriptine or cabergoline, it can create holes in the skull base or holes in the bone where fluid can leak through, in which case it needs to be repaired. It can cause valvulopathy, which means heart valve dysfunction, typically tricuspid regurgitation. So typically patients should undergo an echocardiogram before starting these medications. It can also lead to nausea, vomiting, headaches, dizziness, and things like mania and depression. So typically this algorithm is here. So when a pituitary tumor is suspected and then confirmed, the patient is started on dopamine agonists. Typically they're started on cabergoline, which is more well tolerated than bromocriptine. If the patient is controlled, they go down this pathway on the left here, and then controlled means the tumor has reduced in size, the prolactin level has normalized. If that's the case, we typically repeat a prolactin level annually, as well as visual field testing and MRI imaging to confirm. If it is a control, there is a chance that you can remove the dopamine agonist, typically after 2 years of therapy, and monitor for recurrence. If there is recurrence, then you can restart the treatment. If you administer the dopamine agonist and the patient can't tolerate the medication because of the side effects of nausea, vomiting, headaches, dizziness, or psychiatric problems from it, you can try another dopamine agent, or if that's not the case, then that leads to surgery. The advantage of surgery is that sometimes it's curative, other times it can reduce the prolactin levels to very low levels that medication is not needed, where the patient becomes asymptomatic. But because the medication is so effective, we typically prefer medication first before pursuing surgery. When surgery is pursued, the goal is to reduce the tumor mass, decompress the cranial nerves if they're compressed, curative resection in most circumstances, as well as to preserve the normal gland. This is typically done for patients that have dopamine drug resistance. That's when they're administered bromocriptine, cabergoline, the tumor doesn't respond. The prolactin level remains high. There's side effects from the dopamine medication. If the patient develops apoplexy, which is bleeding to the pituitary gland, or a cerebrospinal fluid leak. Some patients don't want to start the dopamine therapy for a variety of reasons, including fertility issues or psychiatric things, and therefore surgery would be indicated in these circumstances. And some patients with profound hypopituitarism or pituitary dysfunction can benefit from surgery by sometimes regaining some of their pituitary function. So those are the typical surgical indications for prolactinomas. For acromegaly, unlike pituitary tumors, surgery is typically first-line therapy. There was a study that showed that surgery is more effective than medical therapy in terms of cure rates, as well as less in morbidity than medical therapy. If you want to avoid preoperative medical therapy, with the exception of patients with severe sleep apnea or high output cardiac failure. So patients with sleep apnea and high output cardiac failure can undergo medication, which includes analogs to reduce growth hormone productions, including pegvisomant, which is seen here. The goal of surgery is to reduce the IGF-1 levels to normal values for the age and gender, to decompress the cranial nerves if those compress, as well as preserving the normal pituitary gland. So when you suspect acromegaly and then confirm acromegaly, as well as pituitary tumor, with the pituitary scan, it can either be a macroadenoma, a large tumor, or microadenoma, but regardless, once the pituitary gland or pituitary tumor is identified, surgery is pursued. And then the goal is to reduce the growth hormone with less than 2.5 micrograms per deciliter with a normal IGF-1 level. If that's the case, then we observe. If the levels are higher after surgery, you can either do a repeat resection or go to pituitary radiation or medical therapy. And so for Cushing's disease, just like acromegaly, surgery is a first-line therapy. Surgery has been proven to be more higher efficacious in terms of cure rates than medical therapy. The goal of surgery is to reduce the cortisol levels to normal values, decompress the cranial nerves, as well as preserve the normal gland. So when Cushing's disease is confirmed with a pituitary tumor, surgery is pursued. If remission is achieved, it just requires regular follow-up. If surgery is done and there is still persistent elevated cortisol, there's either a chance for repeat surgery or radiation therapy. If that fails, patients can undergo what's called medication therapy or bilateral adrenalectomies, where the adrenal glands which produce steroids are removed. But either way, it requires frequent follow-ups. So when we're doing the surgery, there's several things to typically do the endonasal antiquated sublabia, which is underneath the lip, as well as a craniotomy. The reason why the endonasal route is preferred, as you can see based on this sagittal imaging or side profile, this is the nose, this is the pituitary gland area here. If we stick a camera straight through the nose, it's a straight shot towards the pituitary gland or the sella. We don't have to manipulate any of the brain to get there. So a craniotomy opens up the skull and you have to manipulate the brain to get to this location. The sublabial approach goes underneath the lip and it goes below this upper palate and goes up towards here, and there's a lot of tissue that you have to go through to get there. So patients typically complain of more pain than the endonasal route, which is more minimally invasive or damages less tissue. So we typically go through the nose, through the endonasal route, and this is a cadaveric image of the nose. This is the septum, which is the midline area. The nares or the nostrils are to the side, and these bones are called the turbinates, which are displaced laterally to allow us access to this sphenoid sinus, which is here, which allows us to the pituitary gland, which is what you see here. A septoplasty is done if there's a septal deviation. So if a patient's nose is not midline, we typically correct that by placing in the midline. It helps their breathing, but it also helps us access the area better by allowing us to work through both nostrils. We do what's called a posterior septectomy, where the posterior aspect of the nasal septum or the midline of the nose is removed to allow us both access through the nostrils to the central side of the pituitary gland, so that we can use both hands to remove the tumor. We open the sphenoid ostia, which allows us access to the sphenoid sinus, which then allows us access to the sella. Typically, the bone overlying the sella, which is you've seen here, it has to be opened and thinned and allows us access to the pituitary gland. We preserve the pituitary gland by identifying it early and only removing the tumor. The goal is not to remove the normal pituitary gland. We then reconstruct this bone so that the bone heals by using typically a synthetic material that allows the bone to grow over it. And then we put nasal packing to allow the nose to heal and take out that packing, usually the day after surgery, as well as 2 weeks later with nasal cleaning, so that we preserve sinus function. For functional pituitary tumors, well, for us at Mayo Clinic, we do everything with multidisciplinary team. What that means is different specialties. It's very important for functional pituitary tumors or patients with functional pituitary tumors to have surgery by a specialized team. The reason is that these tumors are very hard to remove a second time around because of scarring. So it's important that these tumors are operated on with the best care the first time around. So typically we rely on a multidisciplinary team to diagnose and evaluate these tumors as well as to operate on these tumors. We do these surgeries in combination with otolaryngology. With neurosurgery, we do the surgeries in combination with each other. We typically have 3 instruments in their nostrils at one time where the camera goes into the right nostril, and then the neurosurgeon typically uses both the right and the left nostril simultaneously to remove the tumor. For functional tumors as compared to non-functional tumors, it's very important that the entire tumor is completely removed, otherwise it's not curative. So we require larger bony openings around the sella so that we can visualize everything to maximize complete removal. Sometimes we have to expose the cavernous sinus, which is where the carotid arteries are, to remove the residual tumors, and sometimes bone that's in front of the sella to allow better exposure, which is the tuberculum bone. We typically want to remove these functional tumors in an extracapsular dissection. What that means is working around the capsule of the pituitary tumor rather than working within the pituitary tumor. By doing that, we maximize the chance that we remove the entire tumor and not leave any microscopic disease behind. Once again, the gross total resection is the goal for these functional pituitary tumors because our goal is to a curative resection if possible. And so this is a visualization of what you get when you work through the nose. You can see here is where the sella is, where the pituitary tumor would sit. This is tuberculum bone that sometimes has to be removed. The carotid arteries are to the side here that sometimes have to be exposed so that we can remove any pituitary tumor that has grown into that side. And then you can see the optic apparatus, which is above here. Some complications that can be associated. The surgery is typically safe. We typically quote complication risk less than 1%. The biggest complication that I consider is that is more common is a lack of hormonal cure. What that means is if we do your surgery for a prolactinoma, Cushing's disease, or an acromegaly, we expect a hormonal cure. A complication would be a lack of a hormonal cure. Sometimes CSF leak or cerebrospinal fluid leaks can happen, which requires a return to the operating room for repair. Typically that occurs less than 1% of the time. You can have pituitary gland dysfunction after surgery. We don't consider changes in your sodium pituitary gland dysfunction, just because with pituitary gland manipulation, sometimes we see what's called diabetes insipidus, where the patient urinates excessively that causes high sodium, or a syndrome of inappropriate antidiuretic hormone where the patient doesn't urinate enough and the sodium goes low because there's fluid retention. Typically, these resolve within 1 to 2 days, sometimes up to a week. Pituitary gland dysfunction includes the steroid production and other things like that that we aim to preserve. Here's an intraoperative video where the tumor is removed here and the pituitary gland is perfectly preserved. Sinonasal morbidity, including smelling, is something that we try to avoid by preserving the nasal fibers. You can have carotid artery injury, which are the carotid arteries, which are to the side of the pituitary gland. It's very rare that this happens, but it can happen, but it's very rare. Infections are also very rare that occur in this area. So postoperatively, after the surgery is done, for prolactinomas, we typically admit these patients to the floor, not the ICU. We get a postoperative day 1 prolactin level. Our goal is to have it less than 10 micrograms per deciliter. We also get an MRI pituitary in all patients. So if that postoperative check, the prolactin level is greater than 10 and the MRI shows a pituitary lesion, we would advocate going back to the operating room to remove it to achieve a curative resection. If the prolactin level is less than 10, then typically it's indicative of a cure. We check the prolactin levels again at 3 months postoperatively and typically annually thereafter. We also check an AM cortisol level to check the function of the pituitary gland. Sometimes patients need supplemental steroids with higher cortisone after these surgery because of pituitary gland manipulation, but typically the pituitary gland is perfectly preserved after these surgeries. Also on the floor, we monitor the sodium and specific gravity. The specific gravity looks at the fluid content or the density in the urine to make sure that the patient doesn't go into what's called diabetes insipidus, which is too much urination, or a syndrome of inappropriate antidiuretic hormone, which is too little urination. And we monitor the patient's ins and outs, how much the patient intakes and outtakes through urine. For acromegaly, we typically like to admit these patients to the ICU. The reason why is that patients with acromegaly Depending on how long they've had the acromegaly, they typically have thickened airways, and so the tongue is thicker, the airway is thicker, so there is a risk of respiratory issues after the surgery, after anesthesia is administered. So I typically like to watch these patients in the ICU to make sure their respiratory status is well monitored. We check a random growth hormone level at the day after surgery, and we like that to be less than 1 microgram per deciliter. Typically, most studies have shown 2.5. We typically like it less than 1. We also get an MRI scan. So if the postoperative scan shows a pituitary lesion and the growth hormone level is greater than 1, typically, once again, we would advocate for repeat surgery on that admission to remove the residual to achieve a curative resection. At 3 months, we check the IGF-1 levels. We don't check the IGF-1 levels immediately after surgery, typically just because it takes a long time, or the half-life of this protein takes a long time to dissolve. So at 3 months, typically we can see if it's a curative resection or not. We also have the patient undergo oral glucose tolerance test to confirm if they have acromegaly still or not. That allows us to evaluate if there's still persistent growth hormone production. After that, if there's a curative resection, we evaluate the IGF-1 growth hormone levels annually. We check an AM cortisol just to evaluate the pituitary gland function, and once again, we monitor inputs and outputs as well as sodium and urine-specific gravities to monitor the pituitary function. For Cushing's disease, we also administer to the ICU. So sometimes, in rare circumstances, what happens is when we do the surgery, we don't administer any steroids so that we can monitor the cortisol levels. After the surgery, especially those patients that have high cortisol levels before the surgery, they can have what we call adrenal crisis. Their blood pressure drops too low, and that's why we want to monitor the ICU to diagnose and identify if this happens. If this happens, the patient has to be administered steroids right away. But typically we try to avoid steroids so that we can get an accurate cortisol level. So post-operative day 1, we get a cortisol level. Our goal is less than 2 microgram per deciliter. If the level is greater than 10, typically it's a failed surgery. We also get an MRI scan. If the MRI scan shows residual tumor and the levels are greater than 2 or greater than 10, we typically advise for going back in to remove the residual tumor. Cortisol levels checked 3 months post-operatively, as well as cortisol annually thereafter. And then we check, just like with the other pituitary surgeries, we check the sodium-specific gravities as well as the inputs and outputs from the patient. So here are some case examples of each. Once again, I'm going to show some operative videos, so it might make some people queasy, so you can turn away during those times, but I'll show you when the video comes up. So here's a case example of a prolactinoma. So this is a patient that presented with headaches and dizziness. So this is a 56-year-old male who was diagnosed with a prolactinoma during a workup for low testosterone. They had low libido. They underwent laboratory testing that showed an elevated prolactin. That led to imaging that showed a prolactin-producing tumor. Their prolactin level was 250, and they were started on cabergoline. He remained on cabergoline for 8 months, and despite escalating doses, the tumor remained large. Here you can see the tumor right here. This is the normal pituitary gland, this is the pituitary stalk, and this is the optic chiasm, and this is the tumor once again. These black structures are the carotid arteries to the side. This is the left carotid artery because it's a portrait view where the right side is the left side, and this is the right carotid artery, and once again, this is the pituitary tumor. With the increasing doses of his cabergoline, he experienced more headaches, dizziness, as well as orthostatic hypotension. He was initially told that his surgery was too complicated because of the involvement of the carotid artery on the left side here. His last prolactin level, despite being on medication, was 54. And so we offered him surgery, as we commonly do these surgeries and have to access the area. And once again, this is the video, so if it makes you queasy, please turn away. I'll try to speed up some of it because it is a couple minutes long. So basically what's happened already is that with the work of otolaryngology, we've accessed the nose. We've gone through the nose, through the sphenoid ostia, which is into the sphenoid sinus, which is this structure here. This is the sella overlying the pituitary gland. This is the right carotid artery, and this is the left carotid artery. On the scans, the tumor eroded into the left cavernous sinus, so we have to expose the left carotid artery, which is what you see here. This is the tumor itself here. This is the left carotid artery, which we're exposing, and this is the left cavernous sinus, which is a venous segment where the carotid artery exists. This is the dura, the lining of the pituitary gland that we have to open. We want to expose all this area. And typically, this is why it requires a multidisciplinary team, because even though you see 2 instruments here, that's 3 instruments because the camera is hovering over this field. The instrument that you saw there was a Doppler to identify the carotid artery, and here we're opening across the dura, or the lining of the pituitary gland, to access the normal pituitary gland, which is what you see here, to access the normal pituitary gland and then the tumor. The space that we're working in is quite small. It looks big on this imaging because of the optics, but each of these instruments are around 2 millimeters in diameter. The drill itself that you saw us drilling was 3 millimeters in diameter. So we're working through about a 6-7 millimeter diameter. Here we're opening up the lining and we're accessing the cavernous sinus. I'll try to speed things up here. So here we're opening over the tumor, entering into the cavernous sinus. And then we're only removing the pituitary tumor here while preserving the rest of the pituitary gland. Here we're trying to do what's called an extracapsular dissection by keeping the capsule of the pituitary tumor so that we don't leave any microscopic disease behind, and freeing it from the normal pituitary gland and then freeing it from the cavernous sinus. You can see here, especially patients that have received cabergoline therapy, it makes the tumor quite fibrous or quite hard. So we have to cut small segments of it out. We can't just simply pull it out, because we want to minimize any potential injury to the carotid artery. And you can see here, we're gently removing piecemeal by piecemeal until the tumor is completely removed. And here you can see the cavernous walls of the carotid artery. And so we have to really access that cavernous sinus to remove the small residual tumor. Otherwise, if we don't remove the entirety, the patient will still have prolactin production, and therefore as a non-curative resection and would still need to be on cabergoline. And this is the Doppler to confirm the carotid artery, just to make sure we know where it is. And as we completely remove the tumor, we're cleaning up all the lining, and then we're also removing what's called the medial wall of the cavernous sinus, or the medial wall, because sometimes there's microscopic disease that adheres to that, and here we're getting hemostasis after complete removal. And so this is that medial wall that we try to transect so that there's no residual tumor. That bleeding you see is normal. It's just the cavernous sinus venous bleeding that stops on its own after we remove that wall. But on the other side of that venous bleeding is the artery that we have to preserve. So it looks bloody, but we only really lose about 10 to 20 cc's of blood. Typically during the case, it's just a very magnified view. After we completely remove the tumor, confirm it, we seal up the area with sealant, and then we cover the area with a synthetic material. This is called biodesign, that recapitulates the bone, and the bone heals over the area, and then we place packing that allows the nose to heal. And so this patient did great. Their postoperative day 1 prolactin was 3.5. Typically we like it less than 10. The MRI showed a gross total resection. So this is the MRI scan. You see it's been completely removed. On the left side, the carotid artery is perfectly fine. We discharged at home to on postoperative day 1 off of cabergoline. Last follow-up at 4 years, he had a normal serum prolactin level off of medication. So for acromegaly, so this is a patient that presented with joint pain and headaches. This is a 55-year-old male who was diagnosed with acromegaly during a workup for headaches and joint pain. He had undergone bilateral knee replacement and scheduled for a right shoulder replacement. In addition, over the past year, he was diagnosed with hypertension and diabetes. His primary care noticed that his jaw was quite large, and upon questioning, his ring size and his shoe size had increased by 2 sizes. He underwent hormonal testing that confirmed acromegaly and an MRI scan that showed a pituitary tumor. This is the pituitary tumor here. This is the normal optic chiasm, and this white line here is his pituitary gland that has been smashed to the side. This is a sideways view of the pituitary tumor, and this is what you see here. His IGF-1 was 995, and the normal range for his age and gender was 223, so quite high. Once again, here's another video. So similar, we access through the nose with otolaryngology. We access the cell, and you can see everybody's cell is a little bit different, and this is his whole cell that's larger than the previous case, but you can see the window is much narrower in the sense the sphenoid sinus floor as well as the roof, it makes it quite narrow. This drill is 3 millimeters in diameter, and we drill the bone overlying that tumor. You can see part of the tumor has eroded through the bone here. So we remove the bone overlying the area. In these cases, we like to have a big exposure just so we can identify everything, and if anything, any of the tumor invades into the cavernous sinus, we're able to access that area. And so that's why these exposures are very important. That's multidisciplinary and done by a team that does these surgeries quite frequently. And so here we're opening the lining of the dura, and you can see here the tumor is quite large and very soft, so we can't remove it completely in one piece. So we have to do it in piecemeal. And so here's the tumor. And once again, this tumor has eroded into the cavernous wall on the right side, so we have to open that cavernous sinus. And this up here is the normal pituitary gland area here that we have to preserve during the case. And so here we're removing the tumor. You can see it's quite large. And so here you can see the normal arachnoid, which is above the pituitary gland, and there's some cerebral spinal fluid that comes through when we remove the tumor because the tumor has eroded through that lining. And here's the rest of the tumor coming out in an extracapsular dissection from the top. And you can see this is the arachnoid where cerebral spinal fluid is behind it. We're making sure that both cavernous sinuses are cleared with special curettes. So you can see here's the right cavernous and carotid artery. Here's the left side with the pituitary gland preserved. Here's the arachnoid. You can see the pulsations of the brain, and to block that cerebrospinal fluid leak, we do the same thing that we did in the other case. Even though we did not have a cerebrospinal fluid leak, we repair or reconstruct it with an artificial substitute here. We also get a nasal septal flap, which is a mucosa that we use as a vascular pedicle to block off the area to minimize any risk of a cerebrospinal fluid leak. And so you can see that nasal septal mucosa or nasal mucosa here, which blocks off any fluid from coming through. And you can see the cavity here where the tumor is completely removed and the pituitary gland is completely preserved. So his growth hormone level dropped to 0.21 nanograms per milliliter. Typically, we like this less than 1. Most studies show less than 2.5, but we typically like less than 1. The MRI also confirmed a gross total resection. He was discharged to home on postoperative day 1. His 3-month IGF-1 level is normal at 218. Remember, before it was 995, and at 4 years, his IGF-1 level was still normal. And so for the next case example is a patient with Cushing's disease. So this is treatment naive Cushing's disease for a patient that did not have previous surgery. So this is a 37-year-old patient who was diagnosed with Cushing's disease during a workup for weight gain. Despite working out regularly and eating healthy, she had gained 60 pounds over the past 2 years, primarily in her abdomen. She also noticed that her skin was thinner, she bruised easier, her hair was falling out. She also noticed that buffalo hump on the back of her neck, as well as thinning of her arms and legs. She also was more emotionally labile with periods of mood swings. She was also diagnosed with diabetes and hypertension, which is a lot for a 37-year-old previously healthy female. This led to hormonal testing and MRI that confirmed a pituitary tumor. So unlike the other cases, you can see this is a very small tumor, which is what you see here, but can wreak havoc on the body. Her labs showed an elevated ACTH level, which confirmed a central source. Her cortisol level was high, and her 24-hour urine cortisol was extremely high. So similar, we access the sella here, the sphenoid sinus area here. You can see in this case, because the tumor is so small, the bony opening over the sella is quite small. It's only this area here. This is your left optic nerve. This is your right optic nerve. And you can see the opening is quite small. It's only about 5 millimeters, 6 millimeters in width. And so here we'd like to expose the cavernous sinuses, which are to the side of access to the area. And here similar, we're opening the dura, but because this one did not extend into the cavernous sinus, we did not have to expose the carotid artery on the left. Here we're just opening the lining of the brain, overlying the lesion, and you can see this is the lesion right here. This is the normal pituitary gland, so we use blunt instruments to try to dissect that tumor out and keep it in its entirety or an extracapsular dissection while preserving the normal pituitary gland. Here we're cutting an adhesion to the normal pituitary gland. Here we're bluntly trying to dissect that away from the normal pituitary gland. And here you can see we're making our way, dissecting it out. And you can see we're working in a 3 millimeter corridor. So it looks big, but it's actually only about a 3-4 millimeter corridor. And here the tumor is removed. And any residual specks, we try to remove that as well. Make sure everything's completely free. That bleeding that you see is perfectly normal. It's just the cavernous sinus. And here we're inspecting just to make sure there's no residual. We're cutting out anything that we suspect is residual because once again, we need to remove it in entirety. Here we're cauterizing any tissue that is free to make sure that's not producing any hormone. And here we're sealing it, and you can see that's the cavity there. We use a synthetic material to reconstruct the lining of the brain, or lining of the pituitary gland, or lining in the brain. Bone grows over that area, and then we seal it in place and put packing to allow it to heal. And so this patient did very well. Their post-operative cortisol was undetectable, less than 1 microgram per deciliter. The ACTH level was less than 5. The MRI showed a gross total resection, which is this opening here. Discharged at home on post-operative day 1 on hydrocortisone. So their cortisol level dropped. So because of that drop, we put them on steroids. We don't like to do steroids once again before because it gives us an erroneous cortisol value. 3 months later, her urine cortisol level was normal, and 5 years, no evidence of any recurrence. So she's in remission. Oftentimes, because we're a tertiary referral center and we specialize in pituitary surgery, we often see recurrent Cushing's disease. And so this is an area that we specialized in, which makes it more challenging than the first time because there's scar tissue, but nonetheless, we see these patients quite frequently. So this is a patient that had recurrent weight gain. She's 18 years old and had undergone a previous surgery 2 years ago. She initially did well after surgery, but noticed increasing weight gain despite lifestyle modifications, mood swings, and acne. She underwent hormonal testing as well as imaging that confirmed presence of a residual recurrent tumor. And you can see it's very small. It's right here, this black area here, right next to the left carotid artery. And you see, even though it's quite small, it's wreaking havoc on her body. Her serum cortisol levels were quite high, 258, and the confirmatory test was 542. Her AM cortisol was a higher level of normal, but her urine cortisol was quite high, 750 and 900. And so here's similar to the last, you can see the patient had previous surgery, the bone had been removed here, as well as here. The residual was on the left side, so we had to drill more across the left carotid artery to access that space. And so this is the left carotid artery here, and we're drilling over the left carotid artery. And so they were dissecting out, and similar to the other cases where there's erosion to the cavernous sinus or the left carotid artery, we have to open up that area to expose it. And so that jet of blood is normal. It just means we're in the cavernous sinus where that tumor had grown into. And so we're opening up that lining. Once again, that bleeding is normal. It's just part of the venous system. That's where that tumor had eroded to. We're using sealant material or what's called gel foam powder to help with the hemostasis. You can see here, we're just accessing the area where there's recurrence. We're not touching the rest of the pituitary gland, which is over there. And there's the tumor. It's quite small, but we're able, it's less than the size of a pea. And this membrane here is the cavernous sinus wall, which the tumor has grown into, so we remove that wall. It doesn't have any functional significance. It just it takes a specialized team to remove that has experience with that. So after we've completely removed it, and then we get hemostasis, remove any residual debris. And then we clean out the area. And similar to the other cases, we put packing material in the area, and then we use a sealant as well as synthetic material for the area to heal, and then put packing across that. So this patient also did really well. Their cortisol was 0.03, which is less than the cutoff of 1. ACTH was 9.9. MRI showed a gross total resection, which you can see here. They're discharged at home on postoperative day 1 on hydrocortisone. 3 months postoperative urine cortisol level was normal, and last follow-up normal cortisol level at 3 years postoperatively. So in conclusion, the most common functional pituitary tumors are prolactinomas, followed by acromegaly or growth hormone producing pituitary tumors, followed by Cushing disease, and least common are the thyroid stimulating hormone secreting adenomas. The diagnosis requires a thorough endocrinological workup and neuroimaging by a specialized team. Surgery is the mainstay treatment for patients with most functional pituitary tumors, except for prolactinomas. The primary goal when surgery is pursued is curative resection. The care of patients with functional pituitary tumors requires a specialized multidisciplinary team that does these tumors and see these patients quite frequently. So our team here at Mayo Clinic in Florida, we have 2 neurosurgeons that specialize in this, myself and my chairman, Dr. Quinones. Our otolaryngologists are Dr. Donaldson, Dr. Olamu, who help us with these approaches. Our endocrinologists are led by Dr. Sampson, as well as Dr. Chang and Dr. Burnett and others who help manage these pituitary patients before and after. In circumstances where we need radiation, Dr. Trifoletti and Dr. Peterson are our neuroradiation oncologists. Our neuro-ophthalmologists are Dr. Pless and Dr. Eggenberger, and then our pathologists, which are critical for diagnosing these as well, as Dr. Gentoff. So thank you, everybody. I'm open for questions now.
Thank you so much for that fascinating and valuable presentation. It looks like everything was thoroughly covered. We have 0 questions that came in this morning. So we really appreciate that. Thank you for just a really great presentation.
Thank you.
And this will conclude today's webinar presentation. We appreciate you taking the time to join us. If you missed any part of this webinar, or if you would like to share it with family or members or friends, it will be available on our website at www.pituitary.org after it is edited. There will be a brief survey after the webinar. Please fill it out to help us provide you with the information you need. Thank you for joining us and enjoy the rest of your day. Thank you again, Doctor.
Thank you.